Hi everyone, can you hear me? Just give me a thumbs up in the chat. Hopefully you can hear me. Yeah, good. Okay, brilliant. We'll make a start. We've got a fair few of you here now, which is great. And thank you so much for tuning in on a Monday evening. Hope work was okay. My name is Shoaib. I'm a doctor based in London and I organize BitePACES. And hopefully you've been tuning into our webinars over the last couple of weeks. We've been doing these webinars actually for quite a while now, and we will be doing so over the coming months in the build up to our course in January and February, um, which will be taking place. And we recently had our courses in September and October, which had some really nice feedback. I'm not going to take up too much of your time. Usmaan is our course lead. He's got extensive respiratory experience and he's currently working in the Allergy and Immunology department in Cambridge. And without further ado, Usmaan, I'll hand over to you and you can take it away.
Perfect, thank you. Can you see my screen?
Yeah, slides are sharing nicely.
Perfect, great. So today we're going to talk about the respiratory exam and then presenting for PACES, because I think based on our WhatsApp survey, that was something that people wanted to talk more about. So before we start, just a little plug for our courses that are coming up. So if you haven't already been on our website and had a look, we have two sets of courses. We have a 4-day comprehensive course, which is a very intense and comprehensive course that covers all aspects of PACES. You'll see lots of patients over the course of 4 days. There's also a day of pure communication teaching, and we have lots of friendly tutors, and it's an excellent way to prepare for the exam. And then if you just want to have a 1-day intensive course, we have a really intense 1-day course where you see lots of patients throughout the day with excellent signs. You'll cover every examination station as well as clinical consultations, get lots of feedback, and all of our faculty are very friendly, but equally they're also quite realistic. So it's a really good way to prepare and see cases that you may not be able to see every day in your places of work, because we have really got some excellent cases available. And we have a discount code called webinar20. So now is the time to sign up if you haven't already. And we will receive some really good feedback, as you can see here. Lots of passes. This person got 100%. And we've got some excellent star rating on Google reviews. So please sign up. I know. Again, hello. So we're going to talk about the respiratory exam and presenting for PACES. The structure of the session is going to be, we're going to talk about a bit of a summary of the station. Then we're going to talk about just little things that people find challenging in the respiratory exam. We're going to talk a lot about presenting, and then some common cases with quiz-based learning, some interaction, and then my top tips for the respiratory exam and a Q&A at the end. So learning objectives today are to be able to do a comprehensive respiratory exam, which I'm sure all of you know, so I'm not going to try to teach you what you already know, but just going to talk about common pitfalls that people make, how to construct a structured clinical presentation, and then just some of the common respiratory cases that people encounter in the PACES exam. So as you all know, I hope, it is station 1, which is respiratory and communication. You have 6 minutes to examine and then 4 minutes to present and be vivaed. So just before I start talking to you, is there anything that people find challenging in the respiratory exam? I think in terms of cases, it's quite, reasonable to learn, but the examination, I think people have their own ways of doing it, and sometimes things don't come off that well. So if you can just type in the chat box any challenges that you guys may encounter or anything that you want to clarify in terms of the actual examination, those 6 minutes to show the examiner you know what you're doing. Okay. Scars, more scars, which we'll talk a bit about in a bit. More time on the back compared to the front, yes. Tracheal exam, yeah. And I want to find difficult to formulate diagnoses. Okay, perfect, fine. And we'll talk about lobectomies versus pneumonectomies in about half an hour's time, Rosemary. And then which lobectomy? Fine, perfect, excellent. So there's all stuff we're going to cover today. So in terms of the examination, so I think firstly, perfect. All right, good. I'll answer all of your questions, guys. So I think if we start in terms of quickly just that hands, the thing that people I think get in a muddle, and this is the case for basically every exam, is clubbing. Everyone tries to do this funny thing with their hands where they get the person to do an M. I mean, the thing is, I understand why people do it. However, in reality, it just is a faff, and some people are not very good at doing the M sign for clubbing. So all you need to do is what is shown on the left. Just look at the nails. If they look clubbed, then you can then prove it by doing your M. If they are not clubbed, there's no point in continuing to do this pointless thing, which doesn't really add anything and can look like a faff. And the point is that in your in the station, really, all the signs are in their chest. And so the aim is to get to their chest as quickly as possible. So you don't want to be faffing about getting them to do this with their fingers and then not be able to do it. And then you like spending time looking at their finger. It just doesn't really add anything. No one's going to dock you marks for not doing it. And it is a low yield thing to do unless they clearly have clubbing when you look at their fingers. Next, and again, in the spirit of keeping time / making your time maximally efficient, you need to examine for a tremor, you need to examine for asterixis, and you also need to feel a pulse and look at the respiratory rate. So whilst you're looking at whether they've got a tremor, at that point you feel their pulse. Then whilst they're looking to see if they have asterixis, at that point you count their resp rate. That way, in the 30 seconds of tremor and asterixis, you've also got an idea of their pulse and also decided whether they have a flap or not. I mean, realistically, it'd be highly unlikely for anyone to have a flap in a respiratory exam in your PACES, but this is the best way of demonstrating it. Equally, at that point, when they're doing these maneuvers, you can also just look at their hands. So another way of just maximizing things. And the reason that I'm like dropping these 2 points home is because the reason people miss signs is because they spend 2 to 3 minutes on the periphery, but in reality, you should be able to get to somebody's chest within 1.5 minutes, really maximum, because really they're not going to have very many signs peripherally in a respiratory exam. The next thing somebody asked about, is it always important to do a lymph node exam? In a respiratory exam, yes, you should examine for the cervical lymph nodes, and also actually you should examine all of their neck nodes in a respiratory exam. In an abdominal exam, you just need to examine the cervical lymph nodes, as in their supraclavicular lymph nodes even. And obviously in cardio, you don't need to examine for any of them, nor in neuro. But in respiratory, you should examine all of the cervical nodes. Chest expansion. Another thing that I think is done really poorly by most people is chest expansion. Most people just like pretend, I think, to feel someone's to examine chest expansion. So this is a good demonstration. Oops. 1 second. Of how to assess chest expansion. Which is, and you know it's done poorly because I watched about 6 videos to find one that it's actually done correctly. So this is how you examine for chest expansion. So upper chest expansion is just like this. You put your hands on the upper chest, but really it's the lower lobes which are where the money is. So when they take a deep breath in, when they take a deep breath out, you put your hands together. And then when they take a deep breath in, your thumb should move apart. If your thumbs are not moving apart, that means you haven't grabbed enough of the chest wall, and you are not really assessing for chest expansion. You're just touching their lower chest. So on deep expiration, you bring in all of their chest muscles, and then on inspiration, your thumbs move apart. One second. Then somebody mentioned about trachea exam. So realistically, you're probably not going to be able to feel tracheal deviation. Even if unless someone's had a pneumonectomy, it's highly unlikely that you'll be able to feel their trachea. So I wouldn't worry too much about it. The way to do it is you put your second and fourth finger on the head of the clavicle, and then you stick your middle finger in towards the trachea, and you're seeing whether it's in the middle or not. But really, unless, as I say, unless they've got a big scar that you've seen, I wouldn't expect to pick that up. It would be odd to. And the last thing is just where to percuss and listen. So first common mistake that people make is they go all the way down one side and then all the way down the other side. We never do that. You always do like for like. Then the next common mistake that people make is they listen in asymmetric places or in odd places, or they listen very like parasternally on one side, and on the other side they listen very laterally. And if you have a panicky examiner, they will think that why is this person not why are they not being symmetrical, essentially. So you always go like for like. The marks, and I know somebody said that they would like to spend more time on the back. This is the age-old problem of what do you do in a respiratory exam? Do you start at the front or do you start at the back? In reality, the marks are almost always on the back. What you should do is just quickly get through the front, because you're probably not going to find anything realistically, and then go on to the back and then finish the exam on their back. So do all of everything on the front. So inspect, because that would be useful. You might find a scar. Percuss and palpate, percuss, auscultate, do your vocal resonance or tactile resonance, tactile thermometers. And once you've done the front, then go on to the back, and then you can breathe a sigh of relief. You've made it to the back, and you listen you do everything on the back, and you can do it in a bit more detail and with a bit more time, hopefully. And if you've practiced enough, you will have enough time on their back to get the result, to get what you want, to find out what you want to find out. And then scars we'll talk about shortly. So hopefully that is helpful. Now, in terms of presenting, the only other thing I want to say before we talk about presenting is the only time when on the back you should you kind of stop with your symmetry is if you find that the person has dullness to percussion on the right side, for example, and you think they've got an effusion, then you've already gone down, and now you can percuss up only on that one side to see where the dullness stops. And this will allow you to evaluate how large the effusion is. And the same with when you're auscultating in the normal fashion, but then at the end of your auscultation, just auscultate up, so you can decide this pleural effusion is small, big, large, or covers this many pleural spaces. And that's a nice way of them knowing. that's a nice way of them seeing that you have established that there is an effusion there. Good. Next, presentations. So your presentations, you should practice presenting in two formats. The first format is a full presentation, which is the one on the left here. I examined a 40-year-old lady. There were or there were not paraphernalia or respiratory disease. They look well. There were no peripheral stigmata of respiratory disease, or peripherally, I noted that she had tar staining. And then examining the chest, whether or not the person was decompensated, my findings are consistent with, and other differentials include. So that's a nice full presentation. It follows the structure of your exam, and it's easy. And if you can do it like that, it lets you conceptualize exactly what's going on because you're talking through the exam, and that way when you're getting to the differentials part, you already your mind is already in gear and you have formatted what you think you're going to say at the end. Now, the problem is that sometimes they don't want you to do that. And so you need to be prepared for them asking you to present your positive findings only. In which case, if you start saying there were no paraphernalia of respiratory disease, they'll just stop you and say, no, no, positive findings only. So in that case, you need to say, I examined this person, or I performed a respiratory exam on this person. You can say whether they look well or they didn't look well, and then you just say my positive findings were. And you list your positive findings. And you have two options there. If you think you know exactly what's going on, you can say my main finding was, and then you can do all the supporting things. So my main findings were bibasal creps, which bibasal fine respiratory creps. And peripherally, I found signs of rheumatoid arthritis. Thus, my differentials are interstitial lung disease secondary to connective tissue disease or secondary to methotrexate or whatever. So that's one way of doing it. That's a bit harder unless it's something obvious. And also unless you finished your exam in 5 minutes, you've got a minute to think, you can then formulate a beautiful presentation in that form. If you get to 6 minutes and you're just finishing off, then you're probably not going to be able to, in a nice way, present your positive findings coherently in like a, this is my main positive, these are other things, and you'll forget stuff. So in which case, there's no harm in saying my positive findings were peripherally, they were clubbed. On examining their chest, the chest expansion was reduced on this side, etc., etc. They're not going to mark you down for doing that, and it may then help you in the same way to figure out what's going on. And again, the same thing, my findings are consistent with other differentials include. For all exams, at the end of the last thing that you should say is, like once you've presented your findings and your differential or your findings, you should say whether or not there were signs of decompensation. So in a respiratory exam, you're basically saying, do they have right heart failure or not? So that's JVP, peripheral edema. In an abdominal exam, so if it was a renal transplant, you're saying whether or not they're decompensated from their renal failure. If it's a liver transplant, whether they're decompensated from the liver disease. If it's a cardiac problem, whether they've got heart failure or not. So the last bit of your examination is showing the examiner that you found, this is what you found, and then you've also assessed whether or not they're decompensated or not from their problem. And that shows the examiner that you are not only know what the, not only know what's going on, but also that you know this is a potential complication, which is useful for them to know. Then just some of my top tips for presenting. So stick to your structure if you can, however complex the findings. This is really important, especially in cases where things are odd or not what you expected, such as an abdomen with lots of scars, neuro exams when they're weird and wonderful. It's really easy to get thrown off. So if you've practiced lots of presenting in your normal structure, you will automatically default to your structure when you are in your exam. And that way, even if something is weird, at least you're not thinking, oh no, how am I going to present this? You just put it into your normal structure. And that's your fallback essentially. Um, and to go along with that, if you find something that doesn't really fit with your case, don't force yourself to put that into your differential diagnosis. So for example, I think the commonest thing is in a neuro case, like sometimes neuro patients have really odd sensory findings, or they claim that, oh, in this one dermatome, I have a bit of reduced sensation compared to the other side. And sensation is quite subjective, unless it's really clear that they've got a peripheral neuropathy or they've got a very clear dermatomal lesion, dermatomal sensory loss. I would say if it's an odd finding, you can mention it that you found it, because obviously the examiner will have heard the patient say, oh yeah, that was a bit less than the other side. But don't force yourself to think my differential diagnosis needs to include that odd sensory loss. If it's a stroke, if it's definitely like a left-sided stroke, but for some reason this person has got a bit of reduced sensation on their left heel, just ignore that in your differentials and just talk about the other stuff. I doubt they will pick you up on it, and it's probably just an anomaly in the exam, and this can happen. And so you need to force yourselves to not get confused by weird things that may come up. Then rule of three. So always have three differential diagnoses at the tip of your tongue for all common presentations. And we'll talk a bit about that from a respiratory case today. Only mention negatives if they are relevant. So the relevant things are, like in a cardio exam, for example, whether they've got peripheral stigmata of infective endocarditis in a valve case. That's important. That's an important negative. There's no point in listing like everything that you could find in the negative. And we've already talked about decompensation, so I won't go over that again. And then finally, in terms of presenting, is the viva part. So another thing that people really worry about, and understandably so, it's not nice to be grilled by two people, but you can do well in this. So I think the things that are important are, number one, obviously not getting flustered, which is easy to say, harder to do. But the more you practice, and by coming on our course, this will be something that you have lots of experience with, being grilled and trying not to get flustered if you don't know the answer, and just having something reasonable to say. And so the best ways around this are, if you can maximize your own presentation, that's obviously better. If you can talk about the investigations yourself and the differentials and why it's this and not this, then that's great. And some examiners will let you do that. So, aim for that, but in other examiners won't. Make sure you know the common answers to the common questions or the common topics. If it's like inexcusable to not know the echo criteria for severe aortic stenosis on exam day. That's like the most common thing that comes up. So you should know that. If the examiners have a bad rep. However, in reality, I think largely they are not that mean on the whole. And so if they say anything else after your differential list, then that means you probably haven't got the answer. And just keep talking, as in keep listing some differentials. And it may be that you just need to cast your net a little wider. If you've already got the differential, there's no point in them saying anything else, because you've already got that mark and they can move on to the next bit, which is to ask you about this problem. Structure your investigations in this order. So bedside tests, then bloods, imaging, and then special tests. If you've always followed the same structure, you won't forget things, and it shows the examiner that your brain works in a logical way, which I think they appreciate, because they are aiming for you to be a med reg. And if you can, answer the questions directly and succinctly. So if they ask you a question which you know the answer to, just tell them the answer. There's like no point in beating around the bush, and there's no point in like giving them long convoluted answers. Just tell them the answer that they want to hear, because that's what they want. If you don't know the answer to the question, then it kind of depends on the question. You can either say I don't know, you can say, well, something that's related to it that you do know to make it seem as though you know things. But there's no harm in saying I don't know. And they'll just ask you another question. They probably have lots of questions. It's harder if you don't know the answer to the first question, which is normally a common thing. But it's better for them to just ask a question that you might know the answer to than for you to beat around the bush and not actually get anywhere, which then just annoys everybody. Okay, good. Any questions about presenting or Viva before we move on to some cases? I'm going to stop sharing for 1 second. Would there be any resources that would be good for common questions you would recommend? Yes. So cases for PACES, I know it's not a very comprehensive, it's not a very thick book, but it generally has most of the common things that you should know. You should essentially know everything in the first parts of cases for PACES, and I think that's largely the level that you should definitely know things at. Yeah, cases for PACES is great. And I think there's some things that you probably add on top of. Leeds Paces, that website, leadspaces.com or something to that effect, is pretty good. I would recommend checking that out if you haven't already, because they also have some good questions and like the kind of Viva questions that you would expect to be asked. Yes, I'm just trying to get my quiz up 1 second. So just give me a second. Oh, all right. So, and if you don't have any experience in fundoscopy and we didn't know what we saw, is it okay to say that I would like to refer the patient to the ophthalmologist? I mean, well, I guess what else are you going to do in that situation? It's non-ideal because clearly that's what they want you to. They expect you to know the answer. And if you are not going to be able to say anything, then that's non-ideal. What I would say is, like realistically in fundoscopy, there's probably like 4 or 5 differentials that it could be. Some kind of diabetes, hypertension, retinitis pigmentosa. There really aren't that many options. Some of them look kind of similar, some of them look really, really different. So hopefully you'll kind of know that it's one of like 3 or 4. Say all of those, and then say, ideally, I would like the patient to see an ophthalmologist eventually. Would be the way of saying it. If you just lead with ophthalmologist, you'll probably fail the station because, like, obviously they wouldn't put it in there if they didn't expect you to kind of know. And in fundoscopy, if they've got like really bad diabetes causing their eye disease, it'll probably be kind of clear they have diabetes. Like, you can sneakily look at their hands to see if they've got any cap marks. You could see if they've got a freestyle libre, that kind of thing. If they're like really old, I mean, if they're really young, they're probably not going to have very bad hypertensive eye disease. So you just try and, if you can't figure it out, just think about base it on the patient. Context is really important. I think that's the key in loads of these things. Context is key. Good. No worries. All right. So now I'm going to try this. So what we would like you to do is let me see if it works for me. Ah, it does. Good. Excellent. So let's start. We choose event. So if you could all, you should be able to see. Okay, so if you have if you are able to, on a phone or something, if you could just scan that QR code, because we're going to have a few questions. Alternatively, you can go to mentimeter.com and the access code is 33608699, which I'll copy into the chat. Then I can copy the QR code to the chat. No. All right, so there's people there. That's good. So now let me share screen again. Fine. So we have from the first question, a few people have answered. So it says, I'll give you one more minute. All right, that'll do. So can you all see the results? So pollen could be found in an IOD case. So have a variety of answers. Almost everybody went for Indian respiratory crackles, which persist on coughing, which is good. They do persist on coughing. I'm going to assume the person who put clear with coughing accidentally pressed that one. Patients could be on LTOT. And then there's some disagreement with the others, which are arrhythmia, normal chest expansion, absence of clubbing. So only 4 people think that it could be an absence of clubbing, and only 10 people think that it could be mechanic sounds. I think that the problem here is that people are seeing ILD and reading IPF, which are different things. Interstitial lung disease, which is just fibrosis, has many causes. one of which is idiopathic pulmonary fibrosis. And thus, other than end in respiratory crackles, all of the others could be there in an IOD case. And we'll talk about that right now. So let me share the correct screen. So, fibrosis, very common case. We've already talked about, so examination findings, classic things. They should be short of breath. They might be short of breath. They might have a cough, L-tot. Then peripherally, they will be clubbed if they have IPF, basically. They may have signs of inflammatory disease. So you need to think about the differentials, which are going to come up in a second. Reduced chest expansion should be the case. However, sometimes it's hard to pick up. You would expect their chest expansion to be reduced, but if they've only got minimal fibrosis, which you can hear, but it's not extensive, then the extensive expansion will probably be normal. They should always have fine respiratory crackles because that's basically what fibrosis is. And there is this theory that they should have a dull percussion note. I mean, which makes sense, right? Because if they've got like a solid bit of lung, because it's all fibrosed, it should be dull compared to aerated lung. However, it's rare to find. And you need to think about what are the signs associated with the cause. So it's really easy to determine that somebody's got, especially if they've got bibasal creps that are fine and end in respiratory that clear on coughing. Like, you've basically got the diagnosis, right? That they've got fibrosis. So what they want to know is what's the cause of this fibrosis. So that's what you need to be thinking about. Is it an autoimmune disease? So do they have mechanics hands and Gottron's papules? Do they have rheumatoid arthritis hands? Have they got scleroderma in their face? Do they have lupus? The arrhythmia, I said, because they could be on a drug like amiodarone, which could give you fibrosis. So that's really what they're looking for to decide whether or not you like the way that you show that you're a good candidate is by picking up the cause of their fibrosis. And if they don't have any of those things, then obviously at that point you're going to have to think, well, do they have IPF, which is important differential? If they're not clubbed, then you may need to think like, well, what are the other things that could cause fibrosis, which may not give you any peripheral signs, which we're going to talk about now. So if we now, you should all have your Menti thing still open. There should be some questions. There should be a question which you can all type into. Can you see it? Aha. And there you are. Good. Excellent. Basically, you guys have got the main things. So the key differentials will be fibrosis or IOD, bronchiectasis, heart failure, bilateral pneumonia. Those are your differentials for basal creps. Good. And then the other things that people have put are causes of ILD, which we're going to talk about in a second. Um, And then the last thing before we move on to the next slide is the next question. I mean, I think because I didn't unshare it, kind of gave the game away, but yes. So back to here. So my differentials are those four things. The differentials for causes of lung fibrosis. So you can say my main differential is this is interstitial lung disease. Other causes of bilateral PrEPs include bronchiectasis, bilateral pneumonia, and pulmonary edema. Given I think this is interstitial lung disease, some differentials for the cause of this are, and then depending on, is it predominantly lower lobe crackles or upper lobe crackles? The more common things that come up in exam cause lower lobe crackles. IPF, rheumatoid arthritis or rheumatological disease, dermatomyositis, scleroderma, drug causes, and then asbestosis, which you don't really see in an exam because those people got other things to do. And then upper lobe predominant crackles are the kind of more prosaic things, angst ABPA, sarcoid. I mean, it's kind of rare to see in an exam. And then hypersensitive pneumonitis, which once it's treated, really the crackle should go away. So again, it would be odd for you to have that in an exam. Just a point here is that somewhere in the chat. Just a point to say is that in your reading, you may come across UIP and NSIP. These are radiological terms for interstitial lung disease, which help with diagnosis. However, they are not really relevant to clinical examination. They're not really relevant to PACES. I wouldn't bother talking about them. Just talk about interstitial lung disease and then talk about cause of interstitial lung disease. That's far more useful than these other terms. Good. And then next question on Mentimeter. Another few seconds. Okay, so the majority of you got them right. So in terms of ratio, obstructive versus restrictive, you all need to know. Obstructive, you have a low FEV1 to FVC ratio. Restrictive, you have a normal FEV1 to FVC ratio. Interstitial lung disease is a restrictive lung disease. Next, in interstitial lung disease, your lung function is impaired, and the bit of it that's impaired largely is your FVC, because obviously half of your lung is fibrosed, thus, yeah, your FVC is reduced. So you have a low FVC. And then transfer factor is how easy does oxygen diffuse from the lungs into the blood, or from the alveoli into the blood. It will be reduced because it doesn't really transfer very easily because you've got fibrosis between your alveoli and your vessels. Hence, you get a reduced transfer factor. You all just need to know the lung function results in ILD, in bronchiectasis, COPD, and that's basically it, which we'll talk about in a second. Oops. Should be back on the PowerPoint. So to to evaluate this further, I would do these things. I'm not going to go into them right now. You'll get the slides. They should be kind of self-explanatory. Bedside tests, blood tests, the imaging, which would be a HRCD, and then special tests, which is essentially a spirometry, actually rather than spirometry, lung function. Spirometry technically is a bedside test. Lung function is the way you get transfer factor. FEV1 and FVC you can just get on the bedside. So full lung function, you would say. Yep. And then in terms of basically, I know we'll talk about some other respiratory diseases, but the main things to say for all of them, you should say basically the same thing, which is smoking for all respiratory disease, either if they're already smoking, smoking cessation is important. Pulmonary rehab is important. Having a flu and pneumonia vaccine, important. So yeah, so unless it's a surgical lung case, bronchiectasis, COPD, asthma, fibrosis, all of them, this is your standard go-to. First things I would do, conservative measures, smoking cessation, pulmonary rehab, flu and pneumonia vaccine. Then in the IOD specific case, I'll treat any underlying cause, like for example, stop their causative medicine. If they've got bird fanciers lung, take away their birds. If they have IPF, then consider pirfenidone or nintedanib, and knowing that there's a FEV1 criteria for that. LTOT is another thing that you all need to understand and know the criteria for LTOT. So you need to know that the PO2 cutoffs 7.3 and 8 for LTOT. We'll go into that now. And then, final option is a lung transplant. So that again, for all of the cases, technically, that could be the end point. If someone's got really bad bronchiectasis, someone's got really bad COPD, if someone has really bad IPF, cystic fibrosis, lung transplants are last thing. Oops. Too many tabs. Next question on Menti. Okay. So we've got COPD followed by bronchiectasis, followed by obesity, and then a few people riding on the scoliosis. COPD definitely causes obstructive lung function. Bronchiectasis also causes obstructive lung function. Obesity and scoliosis and IOD all cause restrictive lung function. So any neuromuscular problem, being obese essentially is a neuromuscular problem because your muscles can't function properly. So you have restrictive lung function tests, same as scoliosis. And then bronchiectasis, COPD, and asthma or the obstructive lung function test result. They may ask you about causes of a mixed picture or a combined obstructive and restrictive picture. So you can put, so textbook definition would be sarcoid, would be one of the causes. I mean, in reality, does sarcoid give you an obstructive deficit as well as a restrictive deficit? I'm not that convinced, but if they ask you in the exam, you can say it. But more commonly, it's a mixed picture. Somebody's got a bit of COPD because of all their smoking, and also they're obese. Common things, common at the end of the day. Good. Bronchiectasis. So things set up. So in terms of bronchiectasis, so coarse crackles again, this time they're clear on coughing. And they'll have a wet cough. And they should be clubbed technically. Then in bronchiectasis cases, you may hear weird sounds like squawks and odd wheezes. And that's just because of all the mucus essentially that's there that's causing them to have these funny noises coming off their chest. And you can just describe them as squawks or squeaks. But the key thing is the coarse creps that alter with the cough. And they may have some lines or scars, marks. Next, so we'll go to the next question. This one's a bit tougher, I guess, than ILD. So things that we have gone for. So cystic fibrosis, recurrent infections, including TB, CF, immunodeficiency, ABPA, CF, Young syndrome. Yeah, good. Okay, perfect. So essentially you can break it down right into infectious causes, genetic causes, other weird causes like ABPA, and we go. So if you think it's bronchiectasis, again, same thing. I found these bilateral crackles if they've got bilateral crackles, or I found unilateral crackles. Differentials include pneumonia, bronchiectasis, focal fibrosis. Most likely thing is bronchiectasis. Causes of this include, and then list off your list. Ideally, you should, have an idea of what you think it's probably going to be. But that may be difficult, in which case the most likely cause is post-infective. In the interest of time, I'm going to skip this. I'm going to skip management. Again, we talked about conservative stuff. The only thing to add in here is chest physio. And the medical therapies for bronchiectasis you should all kind of have an understanding of, which is antibiotics, treating infections promptly, nebulized antibiotics existing, and then eucalyptics, so nebulized saline, carbamazepine. And you should all know what the common pathogens are that people get in bronchiectasis. So that's Haemophilus and Staph aureus. And then the more worrying things are Pseudomonas, and then Burkholderia is very bad. Mm. Every time. Sorry. Next question. This comes onto your lung surgery problem, which I just want to spend the last few minutes talking about. Okay, so let's share screen. So all patients with lobectomies have. So key here, lobectomy versus pneumonectomy. Lobectomy means obviously one lobe has gone. Pneumonectomy means the whole lung has gone. So tracheal deviation towards the side of the lobectomy versus away from the lobectomy. In the lobectomy, you've taken away lung, so the trachea will get pulled towards that side rather than pushed away. So it would be towards rather than pushed away. Now, do all patients with lobectomies have tracheal deviation towards the side of the lobectomy? No. If you've just got a lower lobe lobectomy, why is your trachea that you can feel going to be shifted in any way? It won't be. So only if you've got an upper lobe lobectomy would you have tracheal deviation towards the side, not if you've got a lower lobe one. Next one, breath sounds. So yes, they should have asymmetric breath sounds. So really, if somebody's got an lobectomy, if it's a lower lobe lobectomy, they should have some reduced breath sounds at the base. If it's the upper lobe lobectomy, they should have reduced breath sounds in the upper zones, probably anteriorly. That is a bit difficult to discern. But if you see the scar and you're thinking this person probably had a lobectomy or a pneumonectomy, but you hear some lung sounds, then you hear some breath sounds, then you know immediately this is not a pneumonectomy, this is a lobectomy. Then you need to decide, are the breath sounds reduced at the bases? If they're not, then you're probably not going to be a lower lobe lobectomy. Then have another think about actually were the breath sounds reduced in the upper zone, because that on your first listen anteriorly, you may not have discerned any difference, but may need to come back to it. Lateral thoracotomy scar. So technically, yeah, they should all have a lateral thoracotomy scar. The only caveat is some people have these VAT scars, which are yay big, still in the lateral chest wall, but they're not very big at all. And they may have two port scars and then one like bigger scar, not the classic lateral thoracotomy scar that one is used to seeing. So if they just have these smaller scars, you need to pay attention for that. They're probably not going to be that like well hidden because they've not been doing these surgeries for 20 years. They will have been done in the last 5 years. So you should be able to see the scar definitively, but you need to think like if it's this big, as in if it's like 2 or 3 inches big rather than a full lateral thoracotomy scar, then that sounds more like VAT surgery than anything else. Now, you may then come back and say, well, how do I know it's not a chest drain? Because chest drain holes are small. Next, you may say, well, how do I know it's not a medical VATS rather than a surgical VATS? And again, medical VATS are not that big because medics also do VATS procedures. However, the hole they make is maybe an inch maximum, whereas surgeons put the patients to sleep largely, and they have an anaesthetist, and they have a scalpel, a bigger, and they're more readily happy to use the scalpel than a medic. Thus, the line will be bigger. Dull percussion note, yeah, it should have, but again, if it's just like an upper lobe lobectomy, it'll be really hard to discern. So it doesn't like don't definitely say there's a dull percussion note if you haven't actually elicited it. Yeah. Next. Technically, it should be hyperresonant immediately after the surgery because there's a hole there. But your patients are not going to be immediately post-surgery. By the point that you see them, their chest wall would have filled up with some gunk, like fluid. Amazing. So we've talked about this already. This is what I'm trying to show you. So this is the point I'm making about these two pictures. So that's like classic scar, and the little one is not classic scar, right? Much smaller. And yeah. Oh, and chest expansion. So chest expansion should be reduced actually. If you're assessing it properly, the side which has got the lobectomy should have reduced chest expansion. And obviously, everything I've said also applies to a pneumonectomy, but that would just be more obvious because they'll have more profound signs on the side of their scar. And so for this one, you're saying my differentials include lobectomy, pneumonectomy, could be a single lung transplant, or it could be an MV repair. But if you think that you found extra lobectomy, pneumonectomy, then again, same thing. So I think it's most likely a lobectomy. However, other differentials could be a single lung transplant or MV repair. If it is a lobectomy, differential reasons why someone has a lobectomy include lung cancer, localized bronchiectasis, this list of things. And you should all know the lung function that is expected pre-surgical or pre-surgery. Good. Fine. Okay. We're kind of running a bit late, so we won't talk about pleural effusions. You should know the differentials for a dull lung base. I think this is somewhere in cases for PACES. Just have a look at it. And have an idea for surgery in COPD, because that's like in COPD, they may ask you that as a question. Last thing, so let's just end with some general points to remember for respiratory exam. As we said at the beginning, the answer is basically on their chest at the back. Don't waste her time peripherally. Like within a minute and a half, maximum 2 minutes, you should be on their precordium somewhere. Do the front kind of quickly and then spend the most time on the back. And I think the thing to remember is once you've done the back, once you've finished your exam, if you finish early, you always have time to do whatever else you want to do. But what you can never get back is the time on their back. Like if the time finishes and you haven't finished your exam, then you're never going to be able to finish it. Whereas if you finish the exam quickly, and then you can go back later and like look in the hands in more detail or look in the mouth in more detail or whatever you want to do, you can always do that. And no one's going to judge you for what you do after you finish your exam in the however much time you have left. Do whatever you like at that point. And that should be confirming what you found. So that may be a mindset shift for some of you, but I really want you to try and take that away, that if you can just get to the back and finish your exam quickly, then you have a bit of time to like look at peripherally if you want to find any confirmatory findings. Symmetry is key. We talked about tactile or vocal. Either do tactile parameters or vocal parameters. Pick one. You don't do them both. People find tactile is quicker, so if you want to do that one, do that one. If you just have a habit of doing 99, then do 99. Don't do both. Whenever you hear creps, get the patient to cough, which we talked about. Check their shins and their calves. And then, as we discussed before, always think about right heart failure decompensation. The point is that the examiners should know that you know what happens if someone's lung disease is bad, which is to get right healthy. Fantastic. Good. I knew ran over a bit, but hopefully that was useful. If anyone has any questions, post them in the box. This is another QR code, but this time it's just to a feedback form for me, which I would really appreciate if you could do, please. Let me make sure it works. It does. Yeah, if you could fill that in for me, that'd be great. And if anyone has any questions, please post them in the chat box at the top. Otherwise, the next webinar is on the 10th of November, which is top tips to ace paces for INGs, which is run by our co-lead Shuaib. And as we've already said, sign up to our course and use webinar 20 as a discount code. I'll leave the chat box open for another few seconds. Otherwise, fill in the feedback form and take care, everyone. Good luck with your revision. Hopefully see you at the course. Thank you, Jerry. Right. All right. A minute and